going to discuss about very interesting cases regarding to rickets, which is a common presentation. And we know most cases of rickets are related to vitamin D deficiency, but there are substantial numbers which are related to resistance to vitamin D. And these cases are associated with abnormalities in either the renal handling of the phosphorus, the acid, or the calcium, or there is some problem in terms of vitamin D activation or action. Today, we're going to discuss about 4 very interesting, diverse types of cases, which will focus upon different etiologies of refractory. Boy who presented with rickets and was given a case of vitamin D dose was given. The parents were really concerned about bone pain and a high level of alkaline phosphatase, which was found on follow-up. And calcium levels were normal, and the patient was labeled quote unquote as refractory rickets. Now, as well, we'll discuss about that. We need to understand that once you treat, there are different changes which may happen, which can cause bone pain, and the ALP is a marker of bone formation, and the levels may go up. So this is not really a case of refractory rickets, because once you label refractory rickets, you have to do many complicated investigations like blood gas, PTH, vitamin D, calcitriol, which is not going to help out and will cause more confusion or problem. So this was clearly a simple case in which if we had looked for the line of healing, it was present. So this was a classical case in which we were messing up with a simple case, making it more complicated in that regard. So this was a normal response. On the contrary, we have this 14-year-old boy who presented with rickets with very early onset from around 3 to 4 years. And we can see significant lower limb abnormalities, has received huge amounts of vitamin D. There was no response as far as the radiological picture was concerned. There was no line of healing. And despite that, vitamin D was continuously given, which had unfortunately resulted in nephrocalcinosis. Now, this is a prototype case of refractory rickets in which it was found to have hypophosphatemic rickets. So we have got the 2 extreme scenarios, one where we are unnecessarily messing up a case, and here what we are messing up a case. So this is the scenario which is there from that regards. So rickets can either be missed, and this can have significant consequences. It is a common disorder. 90-95% are nutritional, but we need to identify individuals who are unlikely to respond to vitamin D because they require comprehensive evaluation and assessment from that regards. All of you can go and have a look at our website, Learning.Grow Society, which is a learning portal providing courses about pediatric endocrinology, including fellowship and diploma programs. We do run regular activities in the form of journal clubs, postgraduate lecture series, and grand rounds like this, which provide insights using case-based approaches. We have got publications in pediatric endocrinology, which are available both online as well as in a hard copy. Application also helps in terms of day-to-day management. So today, our agenda would be to focus a bit about rickets to begin with. Then we'll talk about hypophosphatemic rickets, a very interesting case by Dr. Vibha. Then Dr. Yeting will be talking about the case of VDDR. Dr. Musa will also talk about a similar case which we encountered. So just to contrast the 2 approaches there. Then we have a case of proximal RTA by Dr. Manoj and distal RTA via Dr. Dhwani. And this will really complete the entire picture of the 4 major causes of refractory rickets. Now, when we talk about rickets, we are talking about 2 things, calcium and phosphorus. Now, both of them are important for bone formation, but the most important is actually phosphorus. And it's the phosphorus deficiency which is actually responsible for rickets, because phosphorus causes a chondrocyte apoptosis. If the phosphorus levels are low, you will not have apoptosis, and therefore the growth plate will grow more and you will develop rickets. So rickets is essentially a problem of calcium and phosphorus. And we know that the major regulator of serum calcium is actually vitamin D axis. So vitamin D, which is produced either under the exposure of sun or 5% from the plant sources, is then activated by the liver to 25-hydroxyvitamin D, which is further activated via 1-alpha hydroxylase into calcitriol. And this calcitriol then causes the effect which happens in terms of increasing absorption of calcium from 25% to 40%. And if you are deficient in either vitamin D, in 25-hydroxylase, 1,25-dihydroxylase, or if you have a problem in vitamin D receptor, you will develop a refractory rickets. There is also an inactivating pathway of 24-hydroxylase, which inactivates this to inactive form, and which basically results in decreased action from that perspective. Phosphorus levels in the body are largely determined by how much is the urine excretion of phosphorus. So major disorders of phosphopenic forms are associated with low level of serum phosphorus and a high level of urinary phosphorus, which is reflected via a low level of tubular maximum of GFR, which is TMP GFR. Now, phosphopenic rickets needs to be differentiated from the calciopenic rickets, which is basically a calcium and vitamin D problem. But remember, all forms of rickets are ultimately phosphopenic, because if you have calcium deficiency, your parathyroid hormone will go up. And as soon as your parathyroid hormone goes up, you will lose phosphorus in the urine. So everybody with rickets should have a low phosphorus, and that's an important distinguishing point. If your phosphorus is high with rickets, there are only two conditions you're thinking of: renal failure or a pseudo hypoparathyroidism. So phosphorus deficiency is common, but if it is because of secondary hyperparathyroidism, then you will have the calciopenic rickets. While if it's because of a primary tubular pathology, your PTH will not be high, you will basically have a phosphopenic form of rickets. So phosphopenic rickets could be part of a generalized tubular dysfunction like Fanconi syndrome, or a specific problem in which the phosphorus losing substances are more in the body, which is the phosphatonins, typically FGF23, which is acting via the hypophosphatemic rickets. In this condition, you will not only have phosphorus deficiency, but also the increase in calcitriol does not happen. Anybody whose phosphorus goes down should have a high calcitriol. So here the FGF23 not only causes phosphorus excretion, it also causes inhibition of 1-alpha hydroxylase. So these individuals, you need to treat with both calcitriol as well as phosphorus in that regards. There is one exception in which there is a problem of the sodium phosphate pathway, wherein you will have hypophosphatemia with high calcitriol. And this is going to cause you hypercalciuria. So if you have hypophosphatemic rickets, always measure urinary calcium before you start calcitriol, because you may have that NP2 variant which may cause nephrocalcinosis will develop quickly. So this form of rickets typically presents late, predominantly with lower limb abnormalities, and otherwise the child looks normal. He is not sick from that perspective. While the calciopenic rickets can start right from decreased exposure to sunlight, decreased calcium intake, a chronic liver disease with malabsorption, use of anti-epileptic drugs which increase inactivation of vitamin D, abnormalities in the kidney functions like chronic kidney disease, decreased production of calcitriol, which is vitamin D dependent rickets, and you will have an early onset rickets in a sick child who develops tetany and hyperparathyroidism. So if you want to distinguish between calciopenic and phosphopenic rickets, having hypocalcemia, having hyperparathyroidism excludes a primary phosphopenic pathology. This is an important thing to remember. So PTH becomes the second very important investigation when we talk about evaluation of rickets. There is also a third group of disorders, which is because of tubular abnormalities, largely because of metabolic acidosis. Now, these disorders are not really affecting the vitamin D to a great extent. The acidosis itself is causing abnormalities in the bone. So these disorders will present to us with failure to thrive, with polyuria, with nephrocalcinosis, so distal and proximal RTA. Now remember, proximal RTA presents earlier with much lower level of phosphorus. You will have urinary glucose or urinary amino acid uria. The severity of acidosis will be milder in proximal RTA. So you may miss actually these cases. Distal RTA presents a bit later, but the severity of acidosis is much more. You may have hypokalemia. You will develop nephrocalcinosis. And if you don't treat early, you will develop pathological fractures, very, very fragile bone. So later onset, 6 to 10 years of age, significant failure to thrive, hypokalemia, neck flop, fractures, think of a distal RTA. First 2 to 3 years of life, very low phosphorus levels, urinary glucosuria, start thinking of a proximal RTA from that perspective. So now, based upon that perspective, we can classify rickets into deficiency, which is both calcium and vitamin D, in which you can look at the therapeutic response to rickets. Then it may be refractory, which can be calciopenic because of VDDR 1 and 2, renal failure and malabsorption, which is early onset hyperparathyroidism and hypocalcemia. You can have acidosis because of proximal or distal RTA with polyuria, failure to thrive, and if it's distal RTA, you will develop nephrocalcinosis. And finally, you will have the phosphopenic form in which you have hypophosphatemic rickets, Fanconi's disorder or malabsorption associated with late onset lower limb abnormalities with normal calcium in PTH. So if you now remember just two things, phosphorus, calcium, PTH. These three will classify all your forms of rickets and we'll use it for further evaluation. Now the big question is, when you're facing a child with rickets, is it really rickets? If it's rickets, is it refractory rickets or not? And then finally, what is the cause? So rickets, of course, is a radiological diagnosis, but clinical parameters can give you a clue. So you can have a genu valgum, genu varum, and windswept deformity. Now remember, genu varum may actually be a normal phenomena in infants. So if you have a windswept deformity or a genu valgum, that is much more significant. But remember, 1 to 2 years, you can have some form of bony which may happen. And of course, we know about the cupping, fraying, and splaying. All those are characteristic. The next question is it refractory or not? The answer, of course, is that you should give a therapeutic trial of vitamin D and wait for that. So these are the guidelines by the Indian Academy of Pediatrics, which are similar to the consensus statement by the global team. They talk about 60,000 international units fortnightly for 5 doses beyond 12 months or 3,000 international units daily for 12 weeks. So you have to wait for 3 months to get the response, and then you will decide whether it's refractory or not in that regards. Now remember, when you give vitamin D, you will cause increased absorption of calcium and phosphorus. And this calcium and phosphorus will go into the bone to cause deposition and mineralization of the bone. Now, in this scenario, if you are deficient in calcium and you are not giving calcium, you may develop what is known as hungry bone syndrome, or there may be bone pain. So bone pain may be a normal phenomena which may happen. So always give calcium with vitamin D. So this is common. The second thing to remember is that when you are actually giving calcium and phosphorus, the overall turnover of bone will become more. Your osteoblast will act more, your osteoclast will act more, and osteoblast will produce alkaline phosphatase. So alkaline phosphatase levels may rise during the initial phase of treatment. This is basically a marker of a response. It's not a marker of refractory rickets. You have to be cautious about in that regards, and rise in ALP may happen. So the gold standard for response is the line of healing. That is what you need to look at in that regards. So refractory rickets, you need to show that there is rickets, both clinical as well as radiological, and you have given adequate calcium and vitamin D for 12 weeks. There is no line of healing. This is refractory rickets to you. But remember, in certain scenarios, there may be confusion which may cause diagnosis of refractory rickets, particularly, as I said, high levels of alkaline phosphatase, hypocalcemia, and bone pain after treatment, which does not mean that you have rickets. It basically means that this is a normal nutritional rickets which is responding. Wait and watch for more time. Other things which may cause rickets are like skeletal dysplasia, pseudo-hypoparathyroidism, or fluorosis, which may look like rickets. And of course, because they are not rickets, they will not respond to vitamin D, and you may label them as a significant case of a pathophysiological cause. One condition important is hypophosphatasia, and this is characterized via an absolutely low level of alkaline phosphatase. So I've talked about calcium, phosphorus, PTH. The fourth player is alkaline phosphatase. So if your alkaline phosphatase is high, that is a normal response. If ALP is normal, you may be dealing with RTA, which is a low bone turnover. If it's very low, think of hypophosphatasia. So alkaline phosphatase is very important. But many times, first time you are seeing the child, you may think, okay, this is something important. I want to exclude a refractory rickets. So if there is polyuria, fractures, normal nutritional rickets does not cause fractures. So if there is a fracture in a child, significant failure to thrive, you think of refractory rickets. So we've now known that this child had a refractory rickets. a good dose of vitamin D and calcium was given, but still he is not responding. So what's the cause? So from here, we will need to understand what are the causes. So this is from my publication long time ago. And what we see, the four major causes was distal RTA, proximal RTA, VDDR, and hypophosphatemic rickets. And we'll be presenting all four of them in the discussion today. If you go by the Western textbooks, they talk about distal RTA not being a cause of rickets. The reason is if you pick them up at an early stage, they will not develop rickets. But if you delay the diagnosis, like often happens in that regards, you would have a delayed diagnosis and that will cause a significant problem from that perspective. So you need to be cautious about in that perspective to evaluate and assess from that regards. So always take a history of if there is any tetany or any features like that, you can think of a calciopenic rickets. If there is polyuria, it indicates renal tubular acidosis. If there is a primary lower limb abnormality, this is more like a phosphopenic rickets. On examination, if there is anemia, this could be celiac disease or a chronic kidney disease. If there is alopecia, particularly alopecia totalis, this could be a variant of vitamin D dependent rickets type 2, particularly the ligand binding domain causes this. Look for the eyes for the crystals, and this could be an indicator of cystinosis. Hemangiomas, and hemangiomas are important because they may secrete FGF23, and if you remove those tumors, your rickets will improve. That will be an important thing. And of course, if there is mottling of teeth, think of fluorosis as a possibility. Now, if you look at clinical parameter that we have mentioned here, the most important, of course, is calcium. Calcium will, of course, be very low in VDDR. Phosphorus will be low in everybody. ALP will be higher in most, but not that high in distal RTA. So basic parameters will help you out in that regards. And nephrocalcinosis, of course, will give you a direct picture towards the diagnosis of a distal RTA. Important to remember is that amino acid urea, which is a marker of a proximal tubular dysfunction, may also happen in distal RTA because of secondary hyperparathyroidism. So this is the paper that we published there subsequently. So if we now look at the primary causes, I've mentioned those four causes along with renal failure and PHP, so 6 causes. The most important is phosphorus. If your phosphorus is high, it's renal failure or pseudo-hypoparathyroidism. Then calcium, if it is low, it excludes hypophosphatemic rickets. A normal calcium and a normal PTH suggests the possibility of a hypophosphatemic rickets. So generally, everybody who has rickets should have a low phosphorus and a high PTH. If your PTH is normal and phosphorus is low, think of a hypophosphatemic rickets. And of course, urinary calcium, if it's high, it's more like a renal tubular acidosis, and acidosis will also give you a picture. So most important thing is phosphorus, second is PTH, and then of course, ALP and urinary calcium will give you a clue. So back around 17, 18 years ago, we gave an algorithm at that time based upon our results. Results are pretty similar. So this is our current algorithm. So first, of course, is to look for response of vitamin D, maybe wait up to a period of approximately 3 months. If there is response, it's a deficiency rickets. If there is no response, look at phosphorus. If phosphorus is low, you can have RTA, you can have VDDR, and you can have hypophosphatemic rickets. So look for blood gas. If it shows acidosis, that is renal tubular acidosis, you classify using urinary pH, urinary carbon dioxide to blood carbon dioxide difference. You can use this fraction excretion of bicarb into proximal or distal RTA. We'll talk about this a bit later. If the blood gas is normal and your calcium and PTH is also normal, this is hypophosphatemic rickets. While if you have hypocalcemia, you have VDDR, which you can classify using calcitriol level. Low level suggests VDDR1 and high level suggests VDDR2. Remember, calcitriol should be done only when needed. If you do calcitriol level in vitamin E deficiency, the level may be low, normal, or even high. So it's not a very, very good marker because it is affected by PTH. It's substrate independence. These are the all problems which happens with calcitriol. Now, on the other hand, if your phosphorus is high, only 2 diagnoses are there. If creatinine is high, this is renal failure. If creatinine is normal, this is pseudo-hypoparathyroidism. So, of course, look at response to vitamin D, look at phosphorus, low phosphorus, look at blood gas. If blood gas is normal, calcium and PTH, If phosphorus is high, look at creatinine. So this is how you establish the diagnosis. We have specific approach pathways which are dedicated to rickets in our application. You can use them to identify the cause of refractory rickets.
This 15-year-old boy was born of non-consanguineous marriage, and he presented to our OPD with a complaint of not gaining height and weight since 2 years of age. And when we inquired further, his father told us that he was asymptomatic till 2 years of age, when his parents noted that he was not thriving well. He was very short and his weight was very less according to as compared to his cousins. Then he told us that he started walking at around 1.5 years of age. Then they noticed that he gradually developed bowing of legs and protrusion of forehead, but there was no widening of wrist. And child frequently complained of lower limbs, which lead to difficulty in walking. The child looks absolutely normal. He was not sick looking at that time. And he also gave the history that his mother has also short stature and similar kind of lower limb deformity present. At the age of 3 to 4 years, the child developed dental caries very frequently. So they went to the doctors for the dental extraction very frequently. And there was no history of any muscle spasm, any abnormal twisting of the hands. There was no history of any seizure, motor developmental delay, delayed dentation. And they did not give any history of polyuria, pathological fractures, no history of jaundice, diarrhea, greasy stools or clay-colored stools. And he hasn't taken any anticonvulsants. So, when we asked about the treatment history, like for this bowing of legs, they told us that they have taken a lot of treatments for this bowing of legs in the form of syrup calcium and vitamin D for at least 1 year of, for at least duration of 1 year. But they did not get any improvement instead of taking treatment for 1 year. Lot of investigations were done.
Before the investigation, so what do you think about this case? What is the most likely diagnosis for now?
So, as you have discussed, like he was absolutely normal till 2 years of age. So if we and he developed deformities when we started walking, and it mainly developed the lower limb.
So it is a later onset abnormality.
Yes, sir.
And predominantly affecting the
lower limbs.
So could it be VDDR?
So VDDR is a calcopenic rickets, and it has the earlier onset. So
generally speaking, it is unlikely
to have this.
Very clearly mentioned there's no seizure, there's
no
no tenderness.
Yes, sir.
So VDDR becomes
very unlikely.
If you have no seizures, features like cramps
and
pain,
yes,
motor delay, all those things will give you a clue of calcium deficiency. So that is not there. So you look, say, what about RTA? Do you think this could be RTA?
Sir, RTA at this age, definitely proximal RTA they don't give any history of polyuria, which we frequently ask in a patient. The proximal RTA, there is no history. There are failure of
much more failure
to thrive as well.
At this stage. So RTA is nearly out of hypophosphatemic rickets. Could this be
it could be because they have given significant history that the mother has also the similar complaint. So if this is a positive point towards the hypophosphatemic rickets.
So what is the sort of inheritance of hypophosphatemic rickets?
So it is most common is the X-linked dominant. So it could be.
So the most common one is the X-linked dominant, and because of it is X-linked dominant, mothers may also have
similar
milder
symptoms she would have.
Yes, sir. In that regard. So you're thinking of hypophosphatemic rickets
from her, yes, sir.
Carry on.
And they showed us some previous records which showed that X-ray wrist showed some cupping and fraying, and the blood investigation showed like calcium was absolutely normal and phosphorus was on the lower side and ALP was high and vitamin D was slightly normal. So this time he has taken treatment.
Because it's very important to remember that the phosphorus usually in hypophosphatemic rickets is around 1.52.
Yes, sir.
So 3.3 is very difficult to achieve. Because as soon as you give phosphorus, what will happen to PTH?
So PTH will increase.
PTH will increase and will cause wash away of
the phosphorus.
So 7 phosphorus you take immediately will be washed off in the urine. So this is suggestive definitely of an active ricket with the lowest level of phosphorus. Carry on.
So they consulted so many doctors, and there was no significant natal and the postnatal history. There was no history of neonatal seizures, and he was developmentally normal. He came so late at the age of 15 years. So we have the anthropometry of this boy at 15 years of age. His both, as we can see in the chart, both height and weight is affected. It is minus 3 standard deviation, which is showing the nutrition pattern of growth failure. And and now going to the examination, vitals was stable. In the general examination, there was no pallor, no sparse hair, although alopecia. There was dental caries and some teeth were missing due to the extraction. Definitely, so dental caries is important, and it is most commonly present in the hypophosphatemic rickets. So
fluorosis can be the other possibility in which you can have a lot of dental issues which are there. But yes, key pointers. So other pointers of hypophosphatemic rickets are, of course, we talked about late onset, lower limb involvement, the mother. The other important thing is that these dental abscesses, dental extraction, enthesitis, which is a problem in the tendons, all of those things are more suggestive of hypophosphatemic rickets against the otherwise problem.
And still at the age of 15 years, he had mild genuverum. And in the systemic examination, there was no hepatosplenomegaly. And we again run some investigations. And as we can see, the calcium was normal. The phosphorus was on the lower side. It was 2.9. And the VBG, the blood gas was normal. There was no acidosis or alkalosis. The PTH was also on the normal side. There was no hypercalciuria, as urine spot calcium to creatinine ratio was less than 0.25. And the vitamin D was also in the normal range.
So if you put on there, what we are seeing here is that your phosphorus level is low. Now, from our algorithm, if we talk about phosphorus being low, we say you go for a blood gas. And a renal tubular acidosis. So that will be the one possibility to look at. Now, have you done a urinary phosphorus or a TMP-GFR?
No, sir.
Why? Do you think that's very important?
No, sir, definitely.
Why?
Because, sir, TMP, it is.
So
we don't get the exact
factor.
Estimation.
Most people discuss that, okay, you should do a TMP-GFR, it requires the urinary excretion and all those things. But I'll give you a basic message. The major determinant of your serum phosphorus is how much you are losing in urine. You will never be deficient in phosphorus because you always eat. Everything you eat has got phosphorus. So nobody is going to become phosphorus deficient because of decreased intake. It has to be increasing. So if your phosphorus is low, you expect your TMP-GFR to be low. Now, if you look at TMP-GFR, tubular maximum, there are two ways to calculate. One is a nomogram. The other there is a formula. So that formula starts with plasma phosphorus minus phosphorus and other things, which means it will always be below your plasma phosphorus. So if your plasma phosphorus is low, this TMP-GFR is not going to help out. So that's why we have not done in this classical case, we did not do that. PTH is very important. So PTH was normal, which is an important factor. Calcium is normal. And assuming that the blood gas is normal, if you go by our algorithm, this is classically going into hypophosphatemic rickets.
And in the USG KUB, there it showed no nephrocalcinosis. So if we conclude the case, we had a 15-year-old boy with short stature and who has lower limb deformity, and there is a significant maternal history with a similar complaint, and who has dental infections also. So, and there was no response to the calcium and the vitamin D treatment. So if we make a differential diagnosis, the first differential diagnosis that is absolutely the hypophosphatemic rickets. But if we go further, we can think of the vitamin D resistant rickets, but this is very much unlikely because the onset is later in this case, and renal tubular acidosis, hypocalcemia.
Even if there is no hypocalcemia, there is no hyperparathyroidism, which means there is no deficiency of calcium any form. So that makes it less likely.
On the renal tubular acidosis, also there is no polyuria, there is no acidosis found in the blood gas. And the celiac disease, it could be the possibility due to the malabsorption, it could create a similar picture, but the TTG was normal in this case. And if we combine it with our blood investigations, our final diagnosis was hypophosphatemic rickets. And let's see the treatment, how we treat this child. Our main aim was to normalize the serum phosphorus, to increase the bone mineralization, to improve the rickets, and to increase the bone growth. And to increase the serum phosphorus level, bone mineralization, and improve rickets, we gave oral phosphorus with a dose of 50 milligram per kg per day. Adphos comes in a sachet form with the one sachet is equals to 500 milligram. And we give calcitriol also with a dose of 30 nanogram per kg per day, that is a 0.25 microgram TDS. And as he was not gaining height, his father has main concern regarding the height. So we also started the growth hormone in this case with a dose of 35 microgram per kg per day.
On oral phosphorus and vitamin D for quite some time,
yes,
with which his other parameters are good, but his growth is not there. So that's why we are considering growth hormone. We will talk about how growth hormone will be additionally beneficial yes, in this setting.
So let's see what the growth. Let's see about the monitoring. We did 3 monthly monitoring in this child, and we see that the serum phosphorus was normal, and our main aim was to keep the serum phosphorus to the low normal level, because if we increase the serum phosphorus to the normal or the high normal level, it will cause the hyperparathyroidism in this case.
And very importantly, you have to maintain good calcitriol. I talk about that because if your calcitriol is low, you will have higher phosphorus. Calcium will come down and hyperparathyroidism.
Yes.
Hyperparathyroidism will further worsen your phosphorus. So that's why you have to have very good balance between calcitriol and phosphorus.
And as we can say, if we have a low calcium, we have to increase the dose of calcitriol and reduce the dose of phosphorus. And if there is a increase the PTH level, we have to increase the dose of calcitriol and reduce the dose of oral phosphorus. And we should keep the ALP level in the high normal range. But if it is in the lower, we have to increase the phosphorus dose. And if there is a hypercalciuria, we have to decrease the dose of the calcitriol and increase, and we can add thiazide. But there was no hypercalciuria in this case, so we didn't add any thiazide in this case. And the complication that we could face in this child could be secondary hyperparathyroidism, nephrocalcinosis, and but not the growth failure, as we are treating growth in this child with the growth failure, with the growth hormone. Now, some words about the growth hormone therapy, like it is required when the conventional therapy, like the oral phosphorus and calcitriol alone fails to normalize the growth. And what does it do? It increases the renal tubular phosphate reabsorption, and it stimulates 1-alpha hydroxylation of 25 vitamin D. And there is a study which clearly shows the effect of growth hormone in children with X-linked hypophosphatemia. They have used the very high dose, that is the 80 microgram per kg per day. We can use the dose of 35 to 80 microgram per kg per day. That is the pharmacological dose of the growth hormone in this hypophosphatemic rickets. And they have monitored this for 3 monthly. And what they have seen, the increase in the height, Z score in the height, that has increased with the growth hormone therapy. And there was improvement in the TMP, that is that sir was talking about, the tubular reabsorption of the phosphate. And they have also seen the serum phosphate level has also improved with the administration of the growth hormone. So there is a clear-cut benefit of the this growth hormone therapy. So I forget to mention it. Sorry. So there is a clear-cut role of the growth hormone therapy, additional benefit of growth hormone therapy in the hypophosphatemic rickets. Now, there are some words of the novel therapy of the borusumab, and it is an FGF23 monoclonal antibody, and it is what does it do? It increases the tubular phosphate reabsorption, and it increases the 1-alpha hydroxylate expression, and it is required and indicated only when there is a X-linked refractory cases, that is refractory to the conventional treatment, and the severe complicated forms like those who have a dental abscess, secondary hyperparathyroidism.
The major issue that this is actually a more treatment of choice. You are actually correcting the pathophysiology.
Right, sir.
So as it is becoming more available in many of the countries like UK and US and Canada, this has become the standard. So new patients who are diagnosed with hypophosphatemic rickets will be started on this.
Okay.
Old patients, they sometimes are continuing the old therapy. Okay. The biggest advantage of this is that because you are actually correcting the primary pathology, you don't have to give phosphorus from outside, you don't have to give calcitriol
from
all the secondary hyperparathyroidism, all the problems of nephrocalcinosis, temporary problems will be sorted out by using this Borosumab.
Yes,
this is something which is already being used in the Western countries, not available here, but it's very expensive, but this is going to be the way forward.
And the dose required is 0.8 milligram per kg, twice weekly subcutaneous, and the target phosphorus to be achieved is 1.2 millimole per liter, and vitamin D, it should be between 35 to 50 nanograms.
You will be able to get normal phosphorus,
yes, sir, without having hyperparathyroidism. And we have to stop the vitamin D and phosphorus 1 week before starting the Borosumab. Thank you.
So I think this was a very good case highlighting how hypophosphatemic rickets, despite good control, may have growth issues, and we need to work out from that perspective. Important from that regard. So just to summarize, hypophosphatemic rickets is basically because of an increased production of phosphatonin, most important of which is FGF23. Phosphatonin has two actions: increasing the phosphorus excretion and inhibiting 125. So to correct that, you have to basically give phosphorus, as Vibha said, 30 to 50 milligram per kg per day. You also have to give calcitriol around 30 to 60 nanogram per kg per day. So both of them have to be given together. The problem is that if you have a high phosphorus, the PTH will suddenly go up and you will have a hyperparathyroidism that will push off your phosphorus again. So you have to make a balance. Don't give too high phosphorus and don't give too less calcitriol. So both of them have to be balanced from that perspective. So hyperparathyroidism may happen, which you have to worry about. You can also use, some patients have developed tertiary hyperparathyroidism also. So to prevent that, you can use a calcium mimetic like cinacalcet also in certain scenario. And as we discussed, there is possibly a role of Borosumab which will really take care of a lot of these problems, and hypercalciuria, nephrocalcinosis will not happen, which will be avoided. So you may have to give thiazide from that perspective. So there are a lot of other options which are coming up for management in that perspective, and especially with Borosumab, you don't need to give calcitriol, you don't need to give phosphorus, so that's a more physiological regimen from that regards. I also talked about the variant, the NP22 problems, and therefore in that session, scenario, you will develop hypercalciuria. So before you diagnose somebody with hypophosphatemic rickets, always look at urinary calcium. Linda is asking, the children with lower limb deformity have problem with their phosphorus, so it means phosphopenic rickets. You cannot generalize, Dr. Linda, like that. We expect that hypophosphatemic rickets will have a later onset and lower presentation. And this basically is that if you have predominant lower limb abnormalities, in this case, you have to worry about a possibility of phosphopenic rickets if there is no other problems. Dr. Sayan is asking, any specific cause of dental abscesses in hypophosphatemic rickets? There are some local issues predominantly from the dental aspects, and people talk about this happening even without and even with treatment with Borosumab, they tend to continue. So it's not just a direct phosphorus related cause. There is some other issue which is working on that. So patients with Borosumab may have improvement in rickets, but their dental problems may persist, which means that it's beyond phosphorus. There is some other effect of phosphatonin, which is playing a role, Dr. Sayan, there. Dr. Linda is asking, when does one test for 125 dihydroxylase? So calcitriol level, we should keep it only at a very late stage. If we look at our algorithm, we say you start off with phosphorus. If your phosphorus is low or normal, do a blood gas. If your blood gas is normal, do a calcium and PTH. If both are, if you have hypocalcemia with hyperparathyroidism, only in that case, you may do a calcitriol to identify difference between VDDR1 and 2. Dr. Tania is asking from Bangladesh, long-standing distal RTA present with generalized proximal tubular dysfunction. Yes, we have many cases, and that's because of secondary hyperparathyroidism. Your hyperparathyroidism will cause a Fanconi-like picture. So this, in fact, this case, or maybe a severe case like this, already had amino acid urea. So if you remember the chart I presented, 4 cases of distal RTA actually had amino acid urea. That is because of secondary hyperparathyroidism. So what I'm trying to say is that main aim is to look towards a diagnosis. Your diagnosis may not be established on the first day. Often you may have confusion, like we were treating him like VDDR2 initially, but he responded very well. So the main aim is for clinical improvement. So if you keep on thinking of diagnosis and don't give a proper treatment, there's no point. Similarly, proximal versus distal, the issue may be settled later on, but you have to give bicarbonate properly and then you assess from there. So yes, you can all go and have a look at our website, our courses which are available, and the mobile application. So